It is my pleasure to introduce Christopher Shaffer. Chris is a retired high school principal and special education and music teacher of 45 years. He was thrust into an infection crisis when he was diagnosed with E. coli infection, which is resistant to extended spectrum beta-lactamase antibiotics. Rather than continuing on a failing and risky course of treatment, Chris went it alone to find a cure overseas with phage therapy. This presentation is his story. Chris, the floor is yours.
Thank you so much, Kevin, for inviting me, and thanks everyone for being here tonight. I want to start out by just saying, I was a high school principal, a music teacher, and a special ed teacher. And I did that for 45 years. I had zero experience in biology and biological studies. I was just the liberal arts, so I didn't know anything about infections or any of that when all this started. And this is just my story. So the story you're going to hear is simply just through my eyes and what I learned along the way. And as you can see in this picture, when this story started, this is what I looked like. This is where I was when this story started. I was really, really sick. Fever spikes of 102, 103, 104 almost daily, and generally unable to get out of bed. There were times where I was feeling well on antibiotics, but that soon changed. And so why are we all here? Why am I here? Because I want to make life better. And I want to help ease the pain and suffering. That's kind of what I always wanted to do as an educator. I did it in different ways. It wasn't with medications, but it was with a lot of counseling and a lot of talking to students and parents and teachers, try to make life better, ease suffering. And now I want to do that in helping people understand what is phage therapy and how does it work and why should we be doing this? So when we talk about stories, everybody has their story that they have before they became ill, because at some point we're all going to become ill from something, right? And we all had a life before that happened. And you can just see these little pictures I picked out. I was at the gym every day. I was a gym fanatic, and I worked out every day. It was a big part of my life. And you can see me up there in the upper left-hand corner. That was my first communion picture. And here I am praying. And I'm sure Mom told me to do that. And there I am in Fort Lauderdale on the big high chair. And the middle bottom picture is me and President Obama. He visited my school the day before he was elected the second time as president. He spent the day at the school. I got to have lunch with him. It was such an amazing event and such an opportunity. It's something I really cherish, those memories, because I thought he was a great man. And the bottom picture on the right, that's the real me. When you look at that smirk and that grin, that's the real me. Tell me something to make me laugh, make me smile, but please don't tell me no, because I will respond. And that's kind of how I responded with this phage thing. I was being told no, and I was being told, just wait, just keep swimming, and maybe we can save your life, but probably not. And this is my life with E. coli, with ESBL. This is what I looked like. This was the first time I went in to the hospital. The E. coli probably was the result of a botched surgery I had in 2018. I had a diverticulitis episode, which resulted in a perforated colon. Had the resection, everything's fine. I get a hernia over the scar, and I have to have that surgery. So I have that surgery, and then this is kind of as the COVID pandemic is starting. Have the surgery, and we're kind of going into COVID, and what I realized is that surgery was botched. The mesh popped out, and it was forming a debris kind of like barrier in my intestine. And that's why I was in the hospital this time, is that mesh was blocking my intestine. So we resolved that, but this happened a number of times more. And that kind of is the precipitating factor, I believe. I don't think there's any way to prove it, of how I ended up with E. coli. And I'll tell you that a little bit later, but as we're talking. So the first time that I got sick, I thought it was COVID. We were deep in the COVID pandemic. I'd had my second surgery on the hernia to repair the first one. But I was getting really sick. I had terrible flu-like symptoms, fever of 102, 103, 104, body aches, chills. I was sure it was COVID. I didn't even bother taking that first COVID test with the swab up your nose at home. And I thought, well, I'll just run myself down to the airport and get the PCR test because I want to know for sure, is this COVID or not? So I drugged myself out of bed. I'm not sure how I did that, but I did manage to get down to the airport. I had the test done. And a few days before that, right, just before I got sick, I had some routine blood work and some urine analysis. I had that just done as routine that I would normally do every year for my doctor. Thank goodness I did that. So about after 2 days of waiting through this, I woke up after, I think it was 2 days after that PCR test. And I woke up in the morning and my hands were numb. I couldn't feel my hands anymore. And I'm like, okay, this is really bad. I've got to call my doctor. I called my primary care physician and he got on the phone right away with me. And I started to explain my symptoms. He said, "Do you have any other symptoms that you're not telling me about, anything I haven't heard?" And I said, "Well, I have had more of a difficult time urinating." And he said, "Okay, that's really significant." He said, "It sounds like you might have acute bacterial prostatitis and you might be going septic and you need to get yourself to the hospital right away." And he said, "Get yourself there right now, call an ambulance, whatever you need to do." And they rushed me to the hospital. And by the time I got to the hospital, it was kind of coincidental that my tests that I had done previously, a few days before that, all started coming in about the time I got to the hospital. And the blood test and the cultures revealed E. coli with ESBL. And at this point, I had no idea. I'd heard of E. coli, but I'd never heard of ESBL. And I came to learn over the next year what that was and why that was so bad. So they pumped me full of IV antibiotics and they send me home with oral antibiotics, fosfomycin. So I took that for 3 days and I got so sick from the fosfomycin that I had to stop taking that. And then they suggested I take Bactrim. And I did that. And I actually got better. I started feeling better. I even got myself back to the gym. And life was good, right? I was better. This is a later picture with Rhea Kaline. If you get into the phage world, you'll meet this lady. She's one of Dr. Betty Cutter's proteges, probably the closest person to Dr. Betty Cutter, who is the lady who kept phage alive in the United States for the past 50 years. But I met Rhea and we've become good friends since. So I get better. And I think, everything's fine. I'm good. What do I know different? Antibiotics cure you, right? I'm going to get better. This is all done. I can put it behind me. But 6 weeks later, I'm in bed again. I'm sick, same symptoms, and I didn't know what to do. I called my doctor. He said, "You need to get back to the hospital. You need to get more antibiotics." And this is what started the yo-yo syndrome. It was on again, off again for 2 years. On again, off again, antibiotics. What I came to understand with my first lesson was sensitivity panels. This was the first thing I learned. And this is my sensitivity panel. The Bactrim, it was sensitive to Bactrim, but kind of a moderate level of sensitivity. And what I learned is that bacteria can have a real high sensitivity to an antibiotic, or maybe a moderate, or even just barely a sensitivity. So the Bactrim worked initially. But I started seeing more doctors because I was growing more and more concerned because I kept going on again, off again antibiotics. I'm like, I can't live life like this. It's too difficult. I keep getting sick over and over and over. And every time I get sick, the time between when I stopped taking antibiotics and became sick again grew shorter and shorter and shorter. Until at one point, when I went off the Bactrim, it was a day later. I had 105 fever, 104 fever. And it just kept getting worse and worse and worse. And the doctors were only telling me more and more antibiotics. And I was getting incredibly frustrated because what I realized is that these antibiotics aren't going to work. I'm going to die. It was about a year into this. I was like, I'm going to die from this. I can't be cured. And it became very clear to me that I was on a path of death. I was on a death spiral. And what I started doing was I kicked my research into high gear. I love that picture, so I had to include it. But so I really just put all of my effort when I was feeling okay into research, because there has to be something else out there that I can do in order to find a way to keep this E. coli with the SBL from killing me. And I was doing my research, I started becoming really interested in the workings of antibiotics and the workings of bacteria. What do they do once they're inside your body? One of the first things I discovered was biofilm. And biofilms are really the antagonist in this whole story, which they keep the antibiotic from working. And so it's, for those of you who may not understand what biofilms are, it's like this thick gelatinous goo, and it surrounds wherever the bacteria hiding. And these bacteria were hiding in my prostate. So when antibiotics were introduced into my system, they go into hiding in my prostate, and they're surrounded by this force field of biofilm, which doesn't allow the antibiotic inside. And that's really when I knew these antibiotics are never going to work. I have to find something else, because they can't penetrate the biofilm. If it weren't for phages, planet Earth would be covered in this thick mat of bacterial goo, and humans wouldn't be able to exist. So we kind of owe our lives to phages in many ways. So 2 years on, antibiotics are not working. I'm sick all the time. I had to stop working for 6 months because I just constantly had fever. The antibiotics gave me diarrhea. They made me sick. Bathrooms were never close enough. I just couldn't work anymore. You can imagine being in a classroom full of teenagers at the high school level and having a fever of 103. You just can't do that. So I had to stop working for 6 months. But one of the things that happened when I was doing my research, I ran across this word phage therapy. And I thought first, like, well, this sounds crazy. I'm going to have to put a virus in my body in order to get better. Aren't viruses bad? That's all I knew. Viruses are bad, right? We have the polio virus. That's bad. Viruses aren't good. Well, come to find out through my research, well, they can be good. And a light went off in my head that maybe I need to look into this further. Maybe I need to learn more about phage research and phage itself. And I came to really understand what phages are and how they work. So if you're not familiar with phages, this is what they generally are characterized in looking like. So they have a 16-sided head to them where the DNA is stored. And then they have kind of like a stem going down the middle. And then you might think of those as their landing gears. And what happens is when you introduce phage into a host, the phage they're not necessarily swimming around, they're kind of more bumping around. And when they bump into a bacteria, they attach themselves to the bacteria. And there's a little needle, kind of like needle structure or a stem, they call it, a tail, that injects itself into the bacterial wall. And then the tail wiggles, or the bacteria, or the stem wiggles, and that DNA is then shot into the bacteria. And it hijacks the reproduction processes of the bacteria. It no longer reproduces bacteria. The bacterial cell reproduces more phage. It produces thousands inside a bacteria. And then when there's enough, they release an enzyme, breaks down the wall of the bacteria, and those, let's call them baby phages, they burst out, and they do more of that as they are in the host looking for, not necessarily looking for bacteria, but when they bump into them. They aren't really swimmers, but they're bumpers, maybe more like that. But they're very effective. But I was not sold on the idea, because in the United States, you're not going to run into a doctor anywhere in this country who's ever going to say to you as a patient, you should think about phage therapy. The only way I thought about it was because of my own research and what I was doing. And I was coming to understand that this sounds better and better the more reading I do about it. And the more I research on this topic, this has more of a chance of curing me than does antibiotics. However, the FDA doesn't approve it, and you can't really get it in the United States, sort of. So technically, you can get it in the United States. You have to go through all of these processes. Where are the phage physicians in the United States? I can tell you right now, I know them, and there's about 3 of them who are actually using phage. There's one at the Mayo, there's one at Yale, and there's one in San Diego, and there's a couple other around, there's a few in Pittsburgh. The number of physicians who actually know how to deliver and dose phage therapy are really few and far between. As a person, just a regular, let's call them civilians like I was at the time, you're not going to find a physician who delivers phage. And if you somehow come across it, you're going to look at a 2-year waiting list to get in there, even if you can. And in order to do that, you have to start with the paperwork of compassionate use. Again, a civilian, how is a civilian going to handle that paperwork that the FDA wants submitted? Because you have to contact the drug manufacturer yourself. There are no drug manufacturers making phage therapy in the United States. There are phage labs doing it, but they specialize generally in one bacteria. So if you can possibly get your compassionate use waiver approved by the FDA, remember, you have to be on your deathbed in order to do that. And just imagine how you're going to make that process happen. And then if you do, then you've got to find a phage lab who is working in your area of infection. And then you've got to find out who's going to perform phage sensitivity diagnostics in the United States. And where can I have that done in order to find out if the phage that this lab has is going to be effective against my bacteria? Then you have to find out. It just goes on and on. It just keeps snowballing. You have to make a phage cocktail. And what makes a great phage cocktail? Well, there's very few people that understand the science behind making a great phage cocktail, because that comes through years and years and years of experience doing it. There's very few people in the United States who know how to do that. If you can get all that done and get a phage inside of you by taking a cocktail, who can interpret the lab work relative to your phage therapy? Getting all that done, and remember, you have to do it all from here. You can't make that happen. And I came to understand that phage might be possible in the United States, but really it's not. There are a few people that have had it, and I've talked to a number of people in the phage scientific community globally. And it seems like the numbers in the United States are somewhere around between 250 to 400, maybe total patients in the United States who have had phage therapy, either in clinical trials or at some of the places that offer it on a very, very limited basis. And that's over the past 10 years. Since, I don't know if you're familiar with Tom Patterson's case, but he was the fellow who was infected with a bacteria when he was visiting the tombs in Egypt. And he and his wife, Stephanie Strathy, who is an epidemiologist at UC San Diego, they flew him back because he was so sick. And I don't know if you know Stephanie or have heard the story, but he was 9 months in a coma. And at the very last minute, an epidemiologist at UC San Diego, Stephanie, who had never heard of phage therapy before, this is an epidemiologist. We don't teach it in this country. Our doctors, our epidemiologists, nobody really understands it other than this very small circle of people who are involved in phage therapy research. She ran across it probably very similar to how I ran across it in my research. But she had contacts. I had no contacts. She had contacts around the world, and she put out a message to the entire world. And the Belgium team who does phage therapy there had been doing research, just started it 10 years ago. They got the message from her, and they spent night and day for 2 weeks in their lab. They were sleeping in their lab. They found a phage. They flew it over on 2 Learjets and a helicopter on diplomatic pouches to UC San Diego. And I know this because I talked to the guys in that Belgium lab. And this was the purest form because they had to do it IV. And they gave him the IV phage. He had been in a coma for 9 months. 3 days later, he woke up and kissed his daughter. And that's the miracle of phage. But today, we're still not using it. UC San Diego has only done about 17 cases since Tom Patterson's case. So we're still not really utilizing the power of phage therapy. And this is why I decided to fly to Tbilisi. And I'll tell you the thing that put me over the edge. I would study and research every case study that was out there, every research article, and not just the article itself. I would look at the authors who wrote these papers, and I would research them because I wanted to know what they were doing and how they were doing it. And I ran across one case study in particular. A guy named Pranab Johari had gone to Eliava Phage Therapy Institute in Tbilisi, Georgia, and he had undergone phage therapy about 9 years ago now. And I read this case study, and when I was reading all of the names of the authors in the case study, his name, obviously they didn't name him in the case study, but I was able to piece this together by researching him. Like, wait a second, this guy, one of the authors, is the guy that this case study is about. I need to reach out to him. And I did. And Pranab actually called me and we started talking and he told me his story. Lab results right before I flew to Tbilisi. My CFUs, if you're familiar with CFUs, that's the number of viable bacterial cells that can reproduce inside your body. It was above 100,000. That's really bad. And ESBL test was positive. So I flew there on June 7th of 23, and I had to rest for a day once I got there because it takes about a day and a half to get there. I started my treatment on June 9th. The doctor there, Dr. Leah, she was so very matter of fact about it and really put me at ease because when I sat down in front of her, she said, yeah, I think we're going to do 3 20-day cycles of phage therapy and we'll have a break in between of 10 days each. And that should do it. And if it doesn't, we'll do another treatment of phage. We'll study your phage and we'll see if you need a different phage, an updated phage. But this should do it. Our success rate is about 85% when people come here in person and do the phage therapy. And after about 7 days that I was on the phage therapy there in Tbilisi, I saw the doctors every day. And when I went back into the office, she said, we're going to change it up just a little bit. I've talked to the lab and the other doctors here. We're going to have you do a little bit longer first round, and we want you to keep taking the Bactrim because antibiotics and phage can be synergistic. They can work together. And she said, we'll do that because you're pretty sick. I was pretty sick at the time. She said, we'll do that for 30 days this time. And so I did my first 30-day treatment there. And then I brought the rest back with me to the US when I flew back after a month. Now, you don't have to stay for a month. I did because I wanted to meet everyone at Eliava. I wanted to go through the entire treatment for a month there so I could know that this is real. And if anybody ever asked me, because if I knew if I was going to be cured, that I would have to tell people because there's people dying, thousands of people dying every day in the United States from bacterial infections who've never heard the word phage. And that puts me in a tizzy. I want to cry because how can that be the case when we have a treatment which we know works? It has 100 years of science behind it. It works. I'm living proof, yet we're still not using it. And that just seems wrong to me. And I wanted to know these people in Tbilisi so that I could say with confidence, I was cured and these people know what they're doing. And some of the advantages of phage are the antibiotic synergy. So if you're not familiar with this, so when bacteria see phage come into your body, they start screaming bloody murder. They're like, what are we going to do? How are we going to make ourselves resistant to these phage? So in doing so, they have to tear down the wall that they build up against antibiotics oftentimes. And the antibiotics that you were taking, which were either resistant or just barely sensitive to the bacteria, they can become more sensitive. They can become very sensitive to the bacteria. And that happened in my case. So I had another infection along with the E. coli, which wasn't causing me a problem, but I had E. faecalis also. And we treated that. And we initially treated it with Levaquin because when I got my sensitivity testing back, the doctors said, we haven't seen this in a long time, that a E. faecalis is sensitive to Levaquin because it's almost always resistant. And I said, well, I know how that happens because I was taking phage and it reduced the resistance. And and I think that happened also in regard to the Bactrim. because the Bactrim was literally failing. You saw the ESBL, the CFU count was greater than 100,000, and that was on Bactrim. I had been on Bactrim nonstop for 6 months at that point because I was afraid to go off because we knew it was failing. And if I went off again, myself, my primary care physician, were a little concerned that if we went off of it one more time, that the bacteria might not respond at all to the antibiotic. And how am I going to get myself to Tbilisi at that point? So I stayed on the Bactrim. That was just a choice I made, stay on it. Just as soon as the custom phage, which I needed a custom phage, so you can either have an over-the-counter phage or your bacteria requires a custom phage. I wasn't shocked at all when Eliava sent my results back and said, you'll need a custom phage, which takes them about 10 to 12 weeks to make. And as soon as it was made, that's when I got on the air. I got on the airplane 2 days later after they gave me the notice that the custom phage was ready. That's when I got on the airplane. More advantages of phage therapy. There's no known side effects really to phage. There can be some toxins that are released from bacterial cells that could give you a fever or kind of like ooze out of your skin if you have a skin infection or something like that. But really, there's no known side effects. And when I did the phage therapy, I had no side effects. My phage was 2 vials, small vials of liquid a day. It's in a broth that you just drink it on an empty stomach. Phage don't like stomach acid, so you need to do it on an empty stomach. But that's really the only change I had to make was I just didn't have food around the time I was drinking the phage. And phage is known to degrade biofilms. That's really the only thing that I know of that can be effective against a biofilm because they can actually penetrate. They're so small, they can penetrate right through a biofilm and degrade it. They have a high specificity. They target, imagine phage and bacteria evolving together over the past 4 billion years. And each bacteria has kind of like a partner phage, I call it. So the phage only works on that one bacteria. And it touches nothing else in the body, and the host touches nothing else. And as soon as all those bacteria are gone, the phage don't replicate anymore. They're very versatile. They can be used in human medicine. They can be used in agriculture, which is where we most often abuse and misuse and overuse antibiotics is in agriculture. We misuse them in human medicine a lot, but in agriculture, it's phenomenal. And that's causing another big problem in war-torn countries where soldiers are now fighting in trenches where the antibiotics are seeping out of the animals into the fields for the past 50 years, creating superbugs. And now soldiers are getting wounded in these trenches, coming back with superbugs, and they're spreading worldwide. It's a really bad situation we got going on. They're natural. We can go out and find that you probably have 1 trillion phage inside of you right now, or on you too. They're everywhere. Everything you touch has a phage. It's the most abundant source. I don't want to call it a life, but it's kind of a life source. It's the most abundant thing on the planet. They're self-replicating. They need a bacteria to replicate. And when they're inside the host, they reproduce. That's how they work. And they can make antibiotics effective again. Once ineffective antibiotics can become effective again. So those are the big advantage of phage therapy. And halfway through my phage therapy, I was giving a talk at the International Phage Conference that was held in Olympia, Washington, and at Evergreen State College, where Betty Cutter is. She had kept that program alive. She's really the godmother of phage therapy. If you don't know about Betty Cutter, just research her just a little bit to find out who she is and what she's done. I think she's going to be called one day the lady who saved the globe, the lady who saved the world. She kept it together. She kept it going. And she trained people all at Evergreen for 50 years, and they went all over the world. They went all over the world to continue phage therapy. And she's the person responsible for that. She's worked closely with Eliava and the Navy, you name it. She'd worked closely with everyone. When I was giving my presentation at the conference at Evergreen College, I got my first test back, my urine test back, and the E. coli for the first time was under 100,000. This was the first time in 2 years. It was between 10,000 to 25. That struck me. I was like, oh my God, this is the first time I've seen this in 2 years. And when I got that result, I was sitting and listening to a conference. It was Benjamin Chan, who's at Yale, and he was presenting his slides on this very topic. And he was showing how when phage therapy is introduced, how the CFU counts drop precipitously when you're on phage therapy. And I was like, oh my God, I'm looking at my test results. That's exactly what's happening to me right now. And I raised my hand. I said, Ben, Mr. Chen, you have to look at this. These are my test results. And he was like, yeah, that's what happens. So I was really hopeful. I was really hopeful this was working. And it happened just like this. So I had done my second round while I was at that conference. I came back home and I was doing my third round. And in the third round of phage therapy on the 12th day, I got up from bed, went into the bathroom. I was doing my routine like we all do in the morning. You know, I had my toothbrush in my mouth and I was looking in the mirror and I was like, oh my God, it's gone. This E. coli is not inside of me anymore. It's gone. And I knew it was gone. I could literally feel my body healing. It was that pronounced. I could feel it. I could tell. And I tell people this, I could feel my prostate healing. And I sat down on the edge of the tub and I literally started crying. I didn't need a test to tell me that E. coli was gone, that I was cured. I just knew it. And sure enough, 2 weeks later, after I'd finished that last round of phage therapy, it was cured. There was no more growth. Now, this is my most recent on 3/2/25. I still get these tests done. But after 4 months, I was cured of this E. coli. It was gone. And there wasn't a doctor in the United States who gave me that hope. Not a single one. Not a single infectious disease specialist. No one gave me the hope of ever eradicating this infection because of what I've been through. And in 4 months, phage therapy did what antibiotics failed to do over 2 years. And that's the message I want people to hear, because people, for instance, the guy or lady who has the exact same infection I had 2 years ago and is dying today is not going to hear about phage therapy unless they hear it from me or one of the very few other people who are delivering this message. And that person's going to die. And that should not be happening. It doesn't have to happen. And there's reasons it's happening. And I'm going to talk about those. I'm not happy about those. That's why I wrote this book. You know, if you've ever wrote a book, and I'm sure some of you have, you don't make money off of writing books. It's not a profitable enterprise. But I wrote it because I wanted people to know I really have an interest in this. I have skin in the game. I know what I'm talking about. I try to write it in a way that people can understand it, because I didn't understand any of this stuff when I first started. So it's really for the guy or the lady who picks up this book can know right away, I partnered with a friendly virus to cure my deadly bacterial superinfection. I think everybody can understand that. But that's not how most scientists talk about things. Generally, you have to kind of decipher what's going on. And I worked really hard to do that. And I think I did a pretty good job of it. But again, you know, I'm not a scientist and I'm not a doctor. I'm not at least a bacterial scientist, and I'm not a medical doctor. But I know a lot about phage now. So why aren't we using it to its fullest potential? And I think these are probably the biggest reasons that I've identified over the past couple years. Recognition. A lot of people in the phage industry and a lot of people in science want their due recognition. I totally get that. And not necessarily sharing all the information needs to be shared. It's not a bad thing. It's not a good thing. It just kind of is the way all of our careers go, and we want recognition for it. And we don't want to give up secrets necessarily right up front. Research funding, that's been a problem all along. Now it's a disaster. and we all know why. I don't know what's going to happen to research funding. It seems like it's all being cut. I think it's heartbreaking to know that phage may not advance any further than it has now because of the funding. Regulations, I just ran into regulation after regulation after regulation. I think most people would give up the search I was on. I think most people would give that up as soon as they see compassionate use waiver. As soon as they see that paperwork, I think they'd say, oh, hell, I can't do that. I give up. So I think the regulations would stop most people right up front. Public perception, the FDA doesn't approve it. They don't say it's not safe. The FDA actually says it's safe for human use. They just don't approve it because they don't have the data to check all the boxes they need checked. And I think that's a problem because we have 100 years of research on this stuff, and I think we can actually use it. The college curriculum doesn't teach about phage. We know most of our college curriculums are supplemented by the pharmaceuticals, and they have no interest in phage therapy because there's no ROI on phage therapy because it's a natural occurring entity which you cannot patent. You can't own it. So pharmaceuticals are not interested in phage therapy, not right now. Now there is Locus over on the East Coast is doing research in creating phages with the CRISPR technology, editing them so that you can then own those, but there's no data on their use in human subjects. So there's even far less data on genetically modified phages than there is on the natural phages. We have tons of data on the natural phages. But these genetically modified ones, I'm only hearing whispers that they don't bump around as good as natural phages. I'm only hearing whispers about that. I don't know whether it's true or not, but I have talked to a number of scientists who have kind of like explained it that way to me. GMP, the good manufacturing processes, are so laborious that labs aren't willing to do it. Because of the return on investment. If there's not going to be a big, huge return on investment, we certainly aren't going to go through the good manufacturing processes. Belgium has another process they call magisterial, which is not as cumbersome as GMP. And I think that's the way to go. And that's what Europe's going to do. I can tell you right now, Europe is going to use the magisterial process, and that's going to move phage forward. Policies, awareness, a huge one. Awareness is a huge one because our physicians in the United States are not aware of phage therapy. They've never heard of it. I would bet my teacher's retirement that if you went to a doctor today and asked them about phage therapy, they would tell you they don't know anything about it. That's all I ever experienced. Even the infectious disease experts. I only found one who had ever heard of phage therapy. And I'll tell you a real quick story. When I was in an infectious disease expert's office, one of his interns came into the office who had just come out of a very prestigious American medical school. And I asked him, I said, what do you know about phage therapy? He looked at me dumbfounded. He said, I don't know. I've never heard of it. What is it? And I told him, and I said, you're going to be using phage therapy in your future. And all I could see in his eyes was, how quick can I get out of here so I don't have to listen to this guy tell me what I'm going to be doing in my future work as an infectious disease specialist? But I'll tell you what happened. 3 months later, I went back to that same infectious disease specialist, and that intern was with him, and he ran into the room. And he said, you won't believe what happened to me. And he said, we have a patient, and he was over in San Diego. He said, we have a patient, and I won't tell you the specifics around it. He said, we have a patient who needs phage therapy, or he's going to have a transplant. And I'll tell you what kind, because I might be identifying him if I do. But he said, if we don't get the port clear of the infection, he's going to have a transplant. And that's going to result in death because it's not going to work because he's already on death's door now because of this infection. So they were using phage therapy. And he said, you were right. I'm using phage therapy. So I think we have to start using phage therapy to its fullest potential. And we have to get active about talking about it. The time for quiet is over. And you guys might remember who this person is in the middle picture. That's Larry Kramer. Back in the late 1980s or the middle 1980s, and late 1980s. He was one of the AIDS activists as part of ACT UP. And he was out there every day protesting in Washington, getting arrested. ACT UP was getting arrested. They were blocking the streets. And if it had not been for ACT UP and Larry Kramer, we would be nowhere near where we are now in research relative to HIV and AIDS. He's probably the sole person responsible for moving that research along to where it became where it is now. And so one of the things I think we have to do is we have to pass the PASTURE Act. And the chances of that happening right now without hundreds of thousands of people calling their representatives, I think, are zero. But it needs to be passed. Even if it's unfunded, it needs to be passed because it will give labs and doctors the ability to use it without going through the hoops they have to go through now. How many people are affected by AMR, antimicrobial resistant infections? This all comes from the Lancet, that recent, I think that was in September of 24 that they put out that article. But this kind of breaks it down. By 2050, 10 million a year will be dying of bacterial infections. By that year, 2050, they expect 39, I just say 40 million, because we know it's going to be more than that, because new infections are going to merge. And that estimate has been upgraded 3 times since the Lancet started making these predictions. And it's been upgraded by 10 million each time. Now it's up to 39 million. And you can see in this next slide, kind of a graphic. I really like this graphic because it kind of shows you where the hits are going to be biggest. It's going to be Asia and Africa. The low and moderate income countries are always going to suffer more. And they're looking at almost 5 million in Asia, 4 million in Africa. These are just estimates. If no more new bugs emerge, and we know new bugs are going to emerge. This is the number that I pulled out of that Lancet article that I don't think most people saw. They saw the number 39 million direct deaths, 169 million indirect deaths associated with antibiotic resistance or resistance, antimicrobial resistance, not just bacteria, it's fungal and viral, but mostly bacteria. 169 million related deaths will occur by 2050. That's an incredibly huge number. And the number of those deaths in the United States, they're happening right now. We see them every day, and we're not using phage. So what I would propose is that we use a parallel track, just like Larry Kramer proposed back in 1989. The FDA went along with this parallel track where drugs that were being used in studies could be used for people living with HIV, and they did that. And I think we could safely do that with phage therapy. We could make it easier for drugs to be used. We just aren't doing it. And one of the reasons, because this is what phage therapy looks like right now. We have labs over here, we have patients over here, hospitals over there, doctors over there, big pharma over here. We have a squirrel on the loose and we lose focus. We've got diagnostics over here, we've got research, meetings over here. How could it ever work when we have this hodgepodge mix of things going on? This is why only a few people can get it. I read this and this made just perfect sense to me. In 2018, Goldman Sachs asked in a biotech research report, is curing patients a sustainable business model? No, it's not. It's not. And that's the question we got to come to grips with, especially with regard to AMR. If we don't come to grips with that question, more and more people are going to die. Because this is why there are no new antibiotics in the pipeline. They're not coming up. Now, the Indian government says they have one which works on everything. I'm skeptical. Hopefully it does, but I'm very skeptical. I think ROI, return on investments, depends on the model. And I think we're going to have to look at a different model globally in order to bring phage to people. And I think, number one, it has to be a one-stop shop. That's why I went to Tbilisi. They have the institutional knowledge for the past 100 years to cure people. They know how to do it. They know how to administer it. They know how to dose it. They know how to monitor it. They know how to change up the phage if it loses its susceptibility to the bacteria. They can make a new phage. They know how to do all that. That's what brought me to Eliava. I think in order to bring phage to people, it's not going to be the pharmaceuticals that do it. It's going to have to be a global governmental response, because phage is not, it's not going to offer the profit that pharmaceuticals need in order to bring it to the people. It's going to have to be kind of like we did polio back when I was a little kid. You know, the government intervened there. You know, they made it happen. I can remember going into the school gymnasium, drinking the polio vaccine. It's going to have to be like that. We're going to have, government's going to have to take charge and make it happen. Otherwise, people are going to die. And that's really where I end, is that we have to have a model that works. And it's going to take, I believe, after having spent 4 years doing this now, studying, researching it, and enduring a bacterial infection, it's going to take the government worldwide to make this happen. I appreciate you guys listening to this.